post-residual paralysis affecting the upper limb, shoulder, elbow, and hand.
Okay, so you feel that it is post-polio residual paralysis. Any other possibility? Can it be something else?
It can be a obstetric brachial plexus injury.
Obstetric. Is this present since birth?
Parents are not sure. They said he at 2-year age he fell.
No, 2 years. We are saying
2 years is beyond birth.
it's beyond birth. 2 years is pretty beyond birth.
Yes, sir. It's not from birth.
Not from birth.
According to
So it is not obstetric brachial plexus.
Can it be traumatic brachial plexus?
it
Can be.
Okay.
How do you differentiate?
Sir, this is a purely motor asymmetric weakness. So it is unlikely.
There is no sensory loss.
There is no sensory loss.
Where did you look for sensory loss?
So in C5 dermatome, C6.
Supposing we are considering it to be a brachial plexus. What type of a brachial plexus injury is this? Where does it, in the brachial plexus, where does it seem to be likely to be fitting in? You have examined this patient? So is it an upper brachial plexus, lower brachial plexus, or a pan brachial plexus palsy? We are talking very grassroots level things. Okay?
Upper brachial plexus and the middle.
Hand
C5.
is not involved? Hand is not involved?
Hand is involved.
Yeah.
Hand is involved.
How do you say that then?
What
Upper and
involved?
middle only?
Which is more involved? Hand or shoulder or elbow? Or which is more important? Chala ke dikhao. It's got reasonably good function, isn't it?
In hand only the
Upar karo.
thumb is.
So supposing the gross, you see, major part is the proximal limb. Where did you look for sensory loss?
The C5 dermatome or the deltoid.
What is that area known as? So, करके दिखाओ मुझे.
ये और ये बराबर है.
बराबर है या कुछ फर्क है? दोनों बराबर है. सो इस तरफ तुम पहले कह रहे थे कि ज्यादा पता लगता है. This is what happens. This is what happens in the exam. Sometimes a trap is laid and sometimes you have not tested. Sometimes you have not tested. And the examiner asks you and you say that there is no sensory loss. And when the examiner demonstrates to you, there may be a sensory loss. So you have to be very careful about this, okay? This patient incidentally has been examined by me. And I was told at that time that he has some hyperesthesia on the affected side. Okay? But we'll just recheck it. Because this is how the stories can change. Patient's version can change. So we have to be very cautious. Because this is sensory input, you have no thermometer for that. You have no way to sort of test it out. Okay, though we have grading systems now available, but still it is all dependent on what the patient tells you. Whereas the motor evaluation can be very objectively done by the candidate. You have an MRC grading, which is reproducible very well. I usually do not like to touch both the parts, identical parts simultaneously, because I feel that the patient needs to concentrate, and if he has 2 points to concentrate, he can get divided, the attention can divide. I usually test one at a time. This is my way, I may be wrong, I don't know. But this is the reason that I do. ये पता लग रहा है? इसमें और इसमें कुछ फर्क है? फर्क है कुछ? बराबर है. So today he is saying बराबर, so we'll go by that. So there is no sensory loss, so this is a very strong evidence that this may not be. Along with that, this patient has some problem with the thumb. So it would be wise to examine the palm also for a possible sensory loss. Okay? So I presume you have already done it, and we'll go by your impression that it's not there. So if there is no sensory loss, then I think it is heavily loaded in favor of post-polio residual paralysis. Okay, so can you tell us the muscle power or the problems with this leg?
The shoulder is flare, it is dislocatable easily, and this
Shoulder is flare. Okay.
and in elbow flexion there is grade 2 power and grade 0 power in the extension, and there is eighth thumb deformity.
You please show us. Can you show to the audience that there is grade? You said grade 2 power
Elbow flexion.
in the elbow flexors. Which elbow flexor? Deltoid? What are the elbow flexors that you are talking about?
Biceps, trapezius.
Okay, so show us grade 2 power. First, show us that the shoulder is flare. Do something to show us that it is flare. Is that the sign of flareness? If a shoulder is dislocatable, it is flare shoulder. Eh? You have to demonstrate some motor activity, isn't it? If he is not able to, there is no contraction. That is a sign of flareness, isn't it? It is not that you elicit some click and say it is flare.
So there is no active.
So you ask him to abduct, kuch karao to say na usse aise kaise. If I am saying demonstrate, so you will say there is no activity.
हाथ उठा के
ये तो कुछ कर रहा है.
is using trapezius.
You can't so the answer to this is I cannot feel the contraction of the deltoid on asking him to abduct. Okay? Neither he is able to flex or extend the shoulder. No rotations are present, isn't it? And if I try to, the shoulder seems to be subluxated because there is a gap. I can insinuate my fingers between the acromion and the head of the humerus. You can see the normal contour is not there, it's all wasted, and there is no active contraction. Show us the power in the elbow flexors. Grade 2 you said.
So biceps.
What muscles are he using? What are the muscles being used to produce this grade 2 power?
Which muscle is grade 2?
This is because of the common flexor origin and common.
You said elbow flexors are grade 2.
Elbow flexion.
You made this statement, elbow flexors are grade 2. I'm just asking you which elbow flexor is grade 2? आपने बोला biceps और brachialis are the two.
There is no contraction in bicep and brachialis.
So then it is grade 0. Then if there is no contraction, then it is grade 0. But you are demonstrating that it is grade 2. वो कैसे हो रहा है?
There is power in the wrist flexors and the finger flexors,
Mm-hmm.
and there is power in ECU and the extensor trapezius and the.
So this means that in spite of the fact that there is no power in the elbow flexors, this patient somehow is able to flex the elbow when the gravity is eliminated. Okay, there is another finding in this patient which I want to show you, is that if you hold the elbow at 90 degrees and you ask him to एक मिनट रुक जाओ, बोलो उसको, उठाओ, बोलो, see that? You see that? So, and if you put your hand on the medial side and the lateral,
You
just
may not have
this one,
registered when he is flexing. He's clenching his fist. When you ask him to open his fist, he's not able to flex. It's a sign, it's called Steinler's effect.
So this is
Steinler's effect, the patient takes advantage of the common flexor origin, muscles, he grips his finger into a fist, and from here, he uses the common flexors as flexor of the elbow. Okay, so that's what he's showing.
So this is an important point which should be demonstrated in this patient. Okay? And unless you do this and you encourage the patient to do it, he won't be able to do it. Alright? Move to the wrist and hand now.
So in wrist there is a restriction of circulation and
Wrist
don't use.
supination for wrist you want to talk about? In wrist I would like to talk about dorsiflexion and palmar flexion.
there is
In
good
the
power.
forearm I would talk about pronation and supination.
There is good power in the wrist extension.
No power.
Good power.
Good power.
Good power.
Great power.
Show us, show us. Good means grade 4, grade 5, what? Grade 4. Okay.
And wrist flexion, palmar flexion.
This is limiting on the side.
So if it is deviating toward the ulnar side, then which muscle is stronger? FCU is stronger. Okay. What else? What about the finger? What about the hand function?
Hand function is good. The grasp and release is good, but the opponent is not there.
Thumb opponents or something else is not good. Just the opposition is not good or something?
Thumb abduction and
Abduction is not good. His thumb. So what are the movements of the thumb? Can you demonstrate in the normal side?
which are this is adduction.
Okay.
This is abduction.
So adduction and abduction are perpendicular to the plane of the palm. Okay, that's important. Okay.
So this is flexion. This is extension. And this is
Flexion and extension are in the plane of the palm. Okay.
and this is opposition.
That is opposition. What is the most important movement to achieve opposition of the thumb? First is abduction. So the finger first has to abduct, then only it can rotate and oppose. So if you cannot abduct, you cannot rotate. So how many abductors are there for the thumb?
Adductor pollicis is longest and abductor pollicis is
So how do you check for the two separately? Longest is supplied by which nerve?
radial nerve and is attached at the base of the
Brevis is supplied by median nerve. So how do you separate out the function of the two?
So the adductor pollicis longus is attached at the base of the first metacarpal. So we stabilize the metacarpal and ask the patient to abduct. And the brevis is attached with the proximal pelvis. So we stabilize
Base of the proximal
base of
pelvis.
the proximal pelvis and
Radial aspect.
radial aspect.
Okay, all these things are important. If it had it not been for its insertion on the radial aspect, then it would not have been an abductor. Okay? So, your evaluation is that the opponents and the abductor pollicis brevis are not functioning. What about the adductor?
Adductor is functional.
Is this checked?
Weakness is there, but it is active.
Show us. How did you check that? Ask him to grip your finger, okay? With the thumb and the palm. Like a pincer. Yeah. Okay. Is there adduction power there or it's not there? It is there. Okay. So now,
Ask him not to flex the thumb while he's doing that.
if you see this is a typical description which is called ape thumb. The thumb has come in the same plane as the rest of the fingers. Normally the thumb is in a plane in front of the other finger. ऐसे रखो फिर से. Just see, ऐसे रखो. Stretch out नहीं करो. नहीं, बाहर को मत करो, ऐसे ही रखो. ढीला छोड़ दो. दूसरा हाथ भी ढीला छोड़ दो ना. नहीं, other side, normal side. He's trying to hold it back, extend it. Yeah, ढीला छोड़ो. So then you see this? The thumb is going behind, almost in the same plane. The other one, the thumb is in front of the plane. Can you see that? This is the reason why it's called ape thumb. When the thumb comes in the same plane as the other fingers, it's called ape thumb. That's a primate appearance. There is hyperextension of the IP joint, PIP, with flexion at the DIP. Swan neck.
Swan neck.
So these visual impressions you should convey to the examiner.
Alright, so what you said, the grasp and release phenomenon are good in the hand, and this can, I think everybody has already seen this patient doing that, demonstrating it. So what would you do for this patient?
I want to do a stage-wise operation. In stage 1,
Very good.
I want to do a scapular flexoplasty. In stage 2, shoulder arthrodesis. In stage
Before we go on to the surgery, how old was the patient when he developed this?
he noticed it at an age of 2 years,
How old is he now?
25 years.
How has he been managing his life for the last 23 years?
In other words, why has he come now, not earlier?
Does he have an occupation?
He is a dishwasher.
He's a,
Mostly dish in our portfolio.
okay, so he's helping in the household activity, okay, as a professional. Okay.
Over the years, I'm not able to.
Yes, I recall it. Like,
For 23 years he was doing this, he has a profession.
He also complained of pain in his both hips.
Pain in the
Both hips.
pain
Both hips.
in hips. So we are.
you didn't come tell anything about the hip
No,
joint
this is,
examination.
you see, this is not a hip case. This is an upper extremity case kept in the exam. And this is exactly what is going to happen. In short cases, you are not supposed to talk about the hip. That means you were dwelling on other areas. Okay? That is
See,
not the correct way.
Sometimes cases are brought in just from the disability clinic. He may not have come for surgery. He may want nothing.
That's the point. Does the patient feel the need to?
So he came for the pain, but when we examined the
You see, sometimes you have to act like Kushwant Singh. Okay, Kushwant Singh was asked in the ICS interview, why have you applied? Because these questions are superfluous questions. Isn't it? Why have you applied? Why do you want to come into the ICS? So his answer was, you see, all the other Englishmen had answered that, sir, I want to serve the country. See, it is like IAS. I want to serve the country and all these things. And he gave a very simple answer which made everybody laugh. He said, I've heard this service pays you well. Okay? So if this sort of a question is asked, if the boss is asking you this question, you can simply say, sir, for 25 years he did not seek attention, but now he's heard my name. Okay? So he's mustered the courage to get treated, isn't it?
बोलो तो नाली 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 जा तो नाली बना रहा
So I would like you, when you see, this is an extensively paralyzed limb. Okay? There's nothing in the shoulder. practically nothing in the elbow as far as the flexion and extension is concerned. So you have to tell us, you have to first define the discipline.
ਮਰੀਜ਼ ਸਾਰਾ ਮਿਰਜ਼ਾਪੁਰ ਦਾ ਹੀ ਨਹੀਂ ਕੋਈ ਲੱਗਦਾ
What are the problems that you have assessed this patient, isn't it? So you have to tell us what are the problems, and are these problems likely to improve with some treatment, or we can leave him alone also. That would be the second thing. But first let us define what are the problems and how we can help him. Then we can suggest it to him. That is his prerogative. He would say, नहीं साहब मेरा तो कूले का पहले काम करो. बताइए. Let us first define what are the problems. You see, to give you an insight into this patient at the age of 2 years had this problem. So, in children, obviously the better limb will be the dominant limb. Had it been the right side paralyzed, he would have the left side already dominant. So, that story does not hold any good that you would call this, sir, it is the non-dominant limb, so we can leave it alone. Okay? So you have to talk about something which is scientific here. No doubt this is the non-dominant. This has to be the non-dominant limb because it's a paralyzed limb.
He's not able to move his shoulder and elbow to do anything.
Okay?
His hand function is good.
So what is the function of the shoulder and elbow? What does it do?
Here the hand of the body, the elbow flexion is used for the pulling.
So you should understand that the function of the shoulder and elbow is tremendous. You see, the hand, the ability of the hand to position in various positions in space, different positions in space, is provided by action of the shoulder and the elbow. All right? So he is at a tremendous disadvantage. He has lived his life like this, so he doesn't realize it. But as a surgeon, you know that all this is putting him to a very big disadvantage. All right? And for all of you, this patient has been brought here because of the singular reason. He has a functioning hand, a reasonably functioning hand, in spite of the fact that the thumb opponents and abduction is not present here, but the grasp and the release phenomenon is very good. He has good dorsiflexion, palmar flexion of the wrist, grasp and release, and he has a reasonable power in the digits. So unless you have a functioning hand, there is no role of proximal reconstruction. This one point you must carry home today, that unless you have a good functioning hand, or you can improve or you can restore the function of the hand, you should not do any proximal reconstruction. Number one. So this patient already has a good functioning hand. Okay? So there is all the more reason that we should try and do something, if possible, for the elbow and the shoulder.
So in polio, reconstruction is from distal to proximal for the upper limb and from proximal to distal for the lower limb. So you correct the hip deformity first, then a knee, and then the foot. For the upper limb, you improve hand function first, then elbow, and then shoulder. So here is an upper limb polio, improve the upper limb hand function. If there is a need, if there is no need, move to elbow and shoulder. Okay?
So he said Steinler's flexor class. Okay? So why did you opt for that? Any reason? Anything you found in the patient?
There is grade 2 power in there is a contraction in the.
So this is not grade 2 power. You see, this is something which you should either talk about the flexor pronator power, or you should talk about the flexors of the elbow power. So as far as the flexors of the elbow, the conventional prime movers of flexion at the elbow, the brachialis and the biceps are paralyzed. Grade 0 power. But the forearm, you see, these muscles, the flexor pronator origin, is an accessory flexor. It's an accessory flexor of the elbow. And we have demonstrated that when you eliminate the effect of gravity, by passively holding, passively hold it like this and ask him to flex. Okay? So I can feel, my hand is at the flexor pronator origin here. I can feel this muscle contract actively. And he is able to flex the elbow. You see, I can't leave it because it will go back, but I can make an assessment that he is able to flex the elbow through that range of motion. So this is a very important test which tells you that if you do a flexor pronator shift operation proximally, which goes by the name of Stiempler's flexorplasty, it is going to work. It is going to work. Okay? The operation is very simple, that you detach the flexor pronator region, shift it about 2 inches proximal to the medial epicondyle. And the effect of that is that it increases the muscle tension, it increases the lever arm here, and along with that, we aim at creating a 30 degrees flexion contracture at the elbow. We do not ask the patient to extend. Okay? So that all these 3 things, they create a grade 3 power. So the patient is not able to flex against gravity at the moment. After the operation, we expect that he should be able to do that. So it would be advisable, we can recommend to him that we can improve the function of elbow by a simple soft tissue procedure. Alright, so we are moving proximal. As suggested, move from distal to proximal. So after this operation has been performed, we move to the shoulder. What do you plan to do for the shoulder?
Shoulder arthritis.
Okay, why shoulder arthritis? Why not any soft tissue procedure?
Before he talks about shoulder arthrosis, one thing which he missed to explain was the scapular muscle functions. So if you had planned to talk about shoulder arthrosis as a management plan, if you do that without mentioning scapular function, then that's a failure.
In scapular muscles,
So that will answer what he's asking. Why did you plan that?
in scapular muscles, only the trapezius muscle is having power, and the rest of the muscles are.
No, you see, what has been asked by Dr. Matthew is, which are the muscles which you would see that they are functioning before you embark upon suggesting or contemplating shoulder arthrosis?
See, the results of your shoulder arthrosis depend on functioning scapular muscles. So what are those critical muscles which should be there before you tell him, look, I'm going to make you better by doing this surgery?
One is trapezius.
What is trapezius?
Can you demonstrate trapezius to me? पीछे चले जाओ, पीछे
Go behind the patient.
so that everybody can see. Simple maneuver. दोनों कर लो यार. This can be tested simultaneously. So shoulder shrugging. Ask the patient to elevate.
Together, not isolated.
So ask the patient to shrug the shoulders proximally, and you apply resistance, downwards resistance. The power should be grade 5. Okay. Why is this muscle preserved in post-polio? There is extensive paralysis of the shoulder muscles. Why is this muscle preserved?
Likewise,
Huh?
Is it?
What is the nerve supply of the trapezius? Anybody else? Spinal accessory.
It's a cranial nerve.
Spinal accessory. That is why it is spared. Okay? Which other muscle is, you were asked critical muscles. Critical muscle. No. There's one more critical muscle. Anybody? Anybody? Dr. Pulkit. Saket. Push the wall. Ask him to push the wall. Serratus anterior. So have you seen the action of that? बताओ सबको कैसे करते थे? Huh? What punch test? Ceiling punch. My advice to you is do not offer all these exotic explanations. Now, no. Ask him to face the screen.
You have to look at the Punjabi.
For demonstration's sake, you go on the other side of the. Go on the other side. And the correct mode would be that he should be. In these patients, because they do not have the ability, to keep their elbow in extension. There is no harm if you passively extend and ask the patient to push in front. So if he is pushing in front and there is no winging of the scapula occurring on the affected side, then the serratus anterior is good par. And if these two muscles are good par, trapezius and serratus anterior, these are important because the trapezius is, you see, it is a shoulder clock mechanism here. You see, the trapezius is pulling the spine of the scapula in this direction, and the serratus anterior is pulling the inferior angle of the scapula in the opposite direction. So this is how the shoulder clock mechanism is working. Trapezius on one side, serratus anterior on the other side. And it is the scapulothoracic movement which is ultimately going to create shoulder abduction if you fuse the shoulder. If you do not fuse the shoulder, this scapula is, though it is moving, it is not creating a movement of the arm. So you fuse the shoulder and it will start.
So before you fuse, you must check for these two muscles. And in serratus anterior, first is inspection itself will tell you there is winging of scapula. And when you do the test, especially in a paralyzed elbow, both triceps is not there, biceps is not there. You can do the test using a passive extension or using a push of the elbow straight away. You have to demonstrate this before you proceed with shoulder arthritis.
See, as far as the various techniques, as well as the ideal position for shoulder arthrodesis is concerned,